So I've been here at Beth Israel Deaconess for 27 years, along the way treating patients with lymphedema in my own little way. And the world was shook about a year ago when Dr. Single came on board, and you heard Dr. Slavin talk about the history of lymphedema at BIDMC. So a little over a year ago, we became dedicated to looking at treatment of lymphedema in a more organized way. So I think that first and foremost, when we talk about taking care of patients before and after surgery, that's what I'm going to be talking about, we need to think about looking at it in a very organized way. Since we have been treating patients for the past year in a more systematic way, it seems appropriate to start thinking about measurements, because that's really where our decision-making comes from, being informed by the objective measurements and subjective measurements of the patients. So I just wanted to review some of the measurements that we take on all of our patients. And with the caveat that all of the patients are measured without having compression on for 48 hours. I know Dr. Wen had spoken about taking measurements for patients who are out of compression for a week. We've gotten a lot of pushback from some patients who don't want to be out of their compression for any amount of time. So we thought that 48 hours might be a little bit of a compromise, enough time to see a near normal state, so that we can take measurements in their true normal state. Because after all, after a surgical procedure, if we want to try to reduce the reliance on compression, eventually that's every patient's goal, we're really not going to be able to compare unless we have a true state without compression initially. So we take the measurements without compression. For 48 hours, we use the circumferential measurements every 4 centimeters. We use the calculate volume based on the truncated cone formula that Dr. Borson described. And we also do volume measurements using a perometer. We want to be able to compare some of our measurements to what we see in the literature with the circumferential measurements, but since we also have the perometer, which is much faster, we use the volume measurements from the perometer as well. And we're also looking at bioimpedance using the LDEX. So we have a score. We're looking at the difference between left and right. For patients who have bilateral involvement, then we're just recording the resistance measurement, and we'll compare it to their measurements, to their own measurements at later dates. And we're also asking patients to describe their symptoms. We use the LymphQOL. There's a version for the upper extremity and a version for the lower extremity. We've heard a little bit about this already today. And patients fill that out based on their symptoms, mood, appearance, how much difficulty they have dealing with their lymphedema. And we get a score for that. And then we're also using a patient-specific functional score. So patients are asked to pick several activities that they have difficulty with and rate them, so that we get truly at what is meaningful for each patient, because sometimes that LymphQOL just doesn't get at it for each patient, and there's quite a wide variation on what disturbs patients the most. So that gets at their individual functional needs. And then the last thing that we looked at, and we kind of have talked about this for a while, it still doesn't capture what most patients come in and complain about. And it's the time and the money spent taking care of their lymphedema. And that thing that doesn't get necessarily asked on all of the inventories. So one of the things we're starting to look at is the number of hours that it takes for them to manage their lymphedema per week. So if somebody's wearing a sleeve 10 hours a day, 7 days a week, that's 70 hours. If they're using a nighttime garment for another 8 hours a night, if they're lucky, I guess, or 6 hours, however many hours they're sleeping with it, we add that up. So we have a total number of hours per week that it takes them to manage. If they're doing some kind of self-massage, if they're doing some kind of very specific exercise for their lymphedema, we're adding that in so we get a total number. Our hope is that we show as they improve, fewer and fewer hours spent during the week in managing their lymphedema. And sometimes that's the earliest sign that there's improvement. So based on all of those measures, we're making some of our clinical decisions. The goal, preoperatively, we want the patients to get into, after that 48 hours without compression, we take our measurements. We don't take the measurements right before the surgery as part of the workup process. Once they get scheduled for surgery, we have them dedicate the 2 weeks before surgery to really getting their lymphedema under the best control possible. So they go into the surgical procedure in optimum state. So 2 weeks, go back and see their lymphedema therapist, and it's not always one of us here at this institution because we're seeing people from neighboring states, and that we have partnerships with, I see some people in the audience today that are seeing some of our patients after surgery. So we have them see their lymphedema therapist and go back and have a full treatment course for those 2 weeks. Now, some patients, all of these patients are used to dealing with their lymphedema long term. So they're usually pretty skilled at taking care of themselves and managing their lymphedema. Some patients need a little bit more help than others. Some that are highly skilled in doing the bandaging, we don't have to see them as often. Somebody who needs more help and is not really good with the technique in bandaging, we do have to see them more often. But the goal is to get that limb down into the best shape possible going into the surgery. For the lymph node transfer in a hospital, they're going to be staying in the hospital for about 3 to 5 days. And while they're in the hospital, we have our inpatient therapists are seeing the patients. And then when they come back for outpatient care, they're seeing one of the outpatient physical therapists. We're having most of our all of our lymph node transplants up until this point have been into the forearm, taken from the omentum. So as Dr. Wen said, we love the omentum. So here we do love the omentum. The patients, because the flap is going into the proximal forearm, we restrict the range of motion in the elbow. Patients, if it was in the lower extremity, we would restrict the weight bearing. Patients are elevating the limb, and they're going to be elevating the limb for at least the first initial 10 days to 2 weeks. So while they're in the hospital, we give them a posterior elbow splint that they rest in. It helps them maintain not quite full extension, but it will prevent them from flexing the elbow. And they're taught to keep the limb elevated. The physical therapist is seeing him in the hospital. We would do manual lymphatic drainage of the trunk, not of the limb to start with. And we're careful not to put any compression or any pressure over the healing flap until they are given the okay, usually at about 3 weeks after their surgical follow-up. And then patients have some mobility issues that the physical therapist is teaching them, or the occupational therapist in the hospital, how to move, get in and out of bed, sit up, because they have an abdominal incision that sometimes causes some discomfort and some mobility issues. And we teach them how to avoid dependency with the arm in performing their ADLs and getting in and out of bed for safety reasons. They may have to discontinue the elevation momentarily during their activities, but teaching them how to do that safely. And they stay in the hospital for anywhere from 3 to 5 days, and then they go home. And they follow up with their surgeon, and they're going to maintain the splint and the elevation for anywhere from 10 days to 2 weeks. Once they get the okay or the clear, they're going to be referred back as an outpatient, and their lymphedema therapist would see them at about 3 weeks when they can start doing manual lymphatic drainage and compression. So the big change, and it's just what we've always done with the patients before they have surgery, the big change after surgery is now we're using that new lymph node as the go-to. We're doing the manual lymphatic drainage towards that new lymph node. We're doing the bandaging towards that new lymph node. So for the lymph node transfer to the proximal forearm, we're bandaging from the wrist up to the forearm and from the upper arm down in both directions. And we're also doing the manual lymphatic drainage in that direction as well. So the range of motion restrictions would be in place for about 2 to 3 weeks, and then patients can start with some light exercise. If we're doing it in conjunction with the bandaging, we're doing active remedial type exercises. Vigorous or resistive exercises would wait until after 6 weeks. And then at the 6-week mark, patients can start to do more vigorous exercise in a more progressive way. Would start off, slowly and progress them up. And then the goal is to start trying to reduce the compression needed at about 3 months. So, that's a little bit of a trial and error. We'd kind of take a look at what their measurements show, what has their reduction been, if there's been any reduction at all, what have their symptoms been like. Most often our experience is that patients come back and report subjective improvement before we notice any objective improvement. Patients will come back and say, I'll ask first thing, how are you feeling? And they say, it feels great. It's not so heavy. I can lift my arm. It feels softer. And I take measurements, exactly the same. So what is it? That softness, that unquantifiable, that heaviness. They're very subjectively happy, but we don't see any improvement yet. So we've told them ahead of time, you're not going to see really any improvement. You're in this for the long haul. We're going to measure you from 3 months. It may be a year before you see significant measurable changes. But at about that 3-month mark, we're thinking about maybe withdrawing some of the compression. Between 3 weeks and 3 months, the patients are going to transition from using compression bandaging until when we feel like we've gotten good compression, good reduction, and then they're going to transition to getting a custom new garment made for them. So they'd be wearing a compression sleeve, and then at about the 3-month period, would start to have them take it off for short periods of time and see what happens. And based on the response, how much edema they have, what their subjective report is, whether they have any symptoms, we would gradually increase that. And we're going to be measuring patients at 4 to 6 weeks post-op, and then at 3-month intervals for the first 2 years. So we're taking a full set of objective measurements at every 3-month mark, but certainly paying attention to their subjective report in the interim too. So for the LV bypass patients, they're coming into the hospital. Often they're in for that day. They're going home that day. They may stay 1 day. We're also going to be having them elevate the limb. For somebody who has an LV bypass, it's done at the in the axilla. We're going to restrict their flexion no more than 90 degrees initially. For the upper extremity, and for the lower extremity, it would depend on where the bypass was done. And then we're bandaging the patients either in the PACU or just in the outpatient department before they go home, usually because they're not really in a state where they're going to be able to skillfully bandage themselves, and we want to make sure they have good coverage with the bandaging. And then they'd follow up in outpatient with their surgeon. They could start manual lymphatic drainage right away. And that would depend on the patient's needs, and light exercise and normal activity for after that first week. So they'd stay at home with the limb elevated for that first week, and then depending on what their job responsibilities were, they could go back to work or resume their normal light activity. And again, no vigorous activity until after 6 weeks, and then we would start them back on their normal exercise fitness routine and progress them upward. And so that's our post-op surgical protocol. I say, again, we're going to be varying it based on patient need.